Today we are going to discuss about antepartum hemorrhage. In this, we will cover the following topics, which is abruption, placenta previa, and Vasa previa. What is antepartum hemorrhage? Antepartum hemorrhage is bleeding from or into the genital tract after 24 weeks of pregnancy up to before delivery. It can affect up to 3 to 5% of pregnancies, and 1/5 of preterm deliveries are affected by antepartum hemorrhage. The classification of antepartum hemorrhage is following. Minor is less than 50 ml that has settled. Major is 50 to 1000 ml with no signs of clinical shock. And massive is a blood loss more than 1000 ml with or without clinical shock signs. The risk factors of abruption is following. As you can see, with one previous abruption, there is 4.4% chances of recurrence. With two previous abruption, there is 19 to 25% chances of recurrent abruption. Other risk factors, as you can see here, are preeclampsia, fetal growth restriction, polyhydramnios, advanced maternal age, multiparity, intrauterine infection, PPROM, abdominal trauma, smoking and drug misuse, like cocaine and amphetamines. The next is the risk factors for placenta previa, which are as follows, like previous placenta previa, previous cesarean section, one previous cesarean section, two previous cesarean section. The increasing number of cesarean section increases the risk of placenta previa. Previous termination of pregnancy, advanced maternal age, smoking in pregnancy, multiple pregnancy, and any causes of deficient endometrium, which can be because of a previous uterine scar or manual removal of placenta, endometritis, curettage, fibroids, or ART. These are the complications of antepartum hemorrhage. It can be divided into maternal complications and fetal complications. Fetal complications like fetal hypoxia, growth restriction, prematurity, and fetal death. Maternal complications can include anemia, infections, maternal shock, renal tubular necrosis, consumptive coagulopathy, postpartum hemorrhage, long hospital stay, affect the mental health, and cause blood transfusion and its related complications. Let's come to abruption. Abruption is a clinical diagnosis. For coming to the diagnosis, we should ask the history. History of any pain, any bleeding, amount, duration, history of premature rupture of membranes. We should do examination, which includes abdominal examination. The classic presentation of abruption is presence of tenderness or woody feel of the abdomen. The speculum examination is important. It tells us the dilatation of the cervix. We can see if there is any active bleeding. And the digital vaginal examination can be done. That tells us the dilatation and the progress of labor. But it is important to rule out any placenta previa before doing a digital vaginal examination, which can be done by an ultrasound scan. Blood tests are important, like full blood count, group and save, and Clahorror test, which is important in Rh negative pregnancies. Ultrasound can be done, but ultrasound is not a good modality to diagnose abruption. It is more of a clinical diagnosis. CTG monitoring to check fetal situation is important. So these are the examinations that we would do for diagnosis, for reaching the diagnosis of abruption. Now, management. Any bleeding more than spotting will warrant a hospital stay till the bleeding has stopped. A woman who has come with minor bleeding that has stopped can go home the same day. However, if there is an ongoing bleed, it is advisable for the woman to stay in the hospital till the bleeding has completely stopped and she is feeling better before going home. We have to consider steroids if we are anticipating preterm delivery. If there is a major antepartum hemorrhage happening, then we should avoid tocolysis and consider delivering. Post-abruption or after an abruption or an unexplained antepartum hemorrhage, the woman should undergo serial ultrasound scans to check to check for fetal growth restrictions. And if the antepartum hemorrhage is in women less than 26 weeks, we should try and continue conservative management, given that the woman's condition is stable. So these are few key points in management of antepartum hemorrhage. If there is ongoing antepartum hemorrhage, heavy bleeding, then we must consider delivery after covering with steroids. If there is a risk of fetal compromise, or if there are CTG concerns, then delivery should be done immediately by a cesarean section. Otherwise, in a minor or a major antepartum hemorrhage, if the woman is more than 37 weeks, then we can plan an induction and vaginal delivery, which is a better mode of delivery in these cases. We must ensure that we do a continuous fetal heart monitoring by the CTG, that is continuous CTG in labor is important for such women. A woman who's had an APH is at high risk of having a postpartum hemorrhage. So we must ensure that we do active third stage management. In a woman who is Rh negative and is having recurrent vaginal bleeding, we should give anti-D every 6 weeks. Otherwise, as per our policy, anyway, we have to give anti-D for every episode of bleeding. But if there is recurrent bleeding, we should keep giving it every 6 weekly. These are the major principles for management of a massive APH, that is a blood loss greater than 1,000 and or signs of clinical shock. So we have to ensure that we have all the necessary personnel available. We should start our approach by ABCD pathway, that is airway breathing, attach oxygen, check for circulation, put 2 wide bore IV cannulas, send blood group sampling and other bloods, and assess and decide on the timing and mode of delivery. Management of antepartum hemorrhage is, as postpartum hemorrhage, is a team effort and an MDT approach in which all the above professionals should be involved. The important pillars of management are communication between all members, resuscitation, monitoring and investigation, and arrest bleeding by arranging delivery of the fetus. So we have to ensure that we carry out all of these 4 principles simultaneously. Let's come to placenta previa. Now the incidence, a few numbers for you. Incidence at term is 1 in 200. And the prevalence of placenta accreta is 1 in 300 to 1 in 2000. The grades of placenta previa, as you can see here as well, grade 1 is minor, where the lower edge is inside the uterine segment. Grade 2 is marginal, where the placental edge is just touching the os. Grade 3 is the partial, where the placenta is partially covering the cervix, whereas grade 4 is complete, where the placenta is completely covering the os. The term low-lying placenta is the terminology used where the placental edge is less than 20 millimeter from the internal os after 16 weeks of gestation. This is a very important chart because it gives us the management and follow-up for cases of placenta previa and accreta. So let's go through this chart together. A low-lying placenta, that is, it is within the 20 millimeter from the internal os, or placenta previa, that is covering the os, on a scan which is diagnosed for the first time at the anomaly scan around 18 to 21 weeks of pregnancy. Also, we can consider transvaginal ultrasound scan to diagnose placenta previa if there is high BMI or posterior placenta or not good visualization because of the fetal head. So once we've diagnosed this, what do we check? If there is a previous posterior placenta or an anterior placenta with no previous cesarean, Then we will straight away go and do a follow-up at 32 weeks of gestation, which should be done by an experienced and trained sonographer. If the woman has history of placenta accreta or multiple cesarean sections in the past and has an anterior placenta, we must always keep in our mind the chance of having a placenta accreta spectrum. So ultrasound scan, which is the best sensitivity again for diagnosing of placenta accreta, should be done by an experienced sonographer to rule out placenta accreta spectrum. If there is no signs of placenta accreta, we continue the follow-up at 32 weeks of gestation. After this, we do another scan at 36 weeks of gestation to confirm. And then depending on the symptoms, we plan the mode of delivery. If the placenta is not in the 20 millimeter from the internal os or 2 centimeters at 32-week scan, we label the woman as not having a placenta previa and no further scans are required. However, if it is low-lying or placenta previa at that scan, if the woman is asymptomatic, she is not having any bleeding, not having any symptoms, then we schedule steroids at 34 to 36 weeks of gestation and scan the woman again around 36 weeks of gestation. If still placenta previa, then we schedule a cesarean section delivery between 36 and 37 weeks of gestation. If there is a recurrent bleeding in these cases, then we consider steroids before 34 weeks. And if it's still previa, we schedule a cesarean section at 34 to 36 weeks of gestation, depending on the clinical symptoms. If it is a low-lying placenta, but not a placenta previa, asymptomatic, then we do a repeat scan at 36 weeks. And if it is still low-lying, then we have to plan the delivery according to the patient's condition, patient's wishes, and the clinician's experience. If there are signs of placenta accreta spectrum, then we have to refer the woman to a center that is equipped in management of such women who are having placenta accreta. So we have to refer them to the multidisciplinary center for further management and delivery. So this is a very important follow-up algorithm that answers most of the questions that come on the topic of placenta previa. So I would really recommend going through this chart and revising it. So for placenta previa, transvaginal ultrasound is the best and the safest method for diagnosis. Use of cerclage to prevent bleeding or to prevent preterm delivery does not have enough evidence to support it. Tocolysis should only be considered in a woman with placenta previa or who's having some minor bleeding, only to cover for steroids. Otherwise, it is not considered a good modality to consider prolonging the pregnancy in women with antepartum hemorrhage and placenta previa. Delivery in cases of placenta previa, we do anticipate major PPH and we prepare for it. While consenting the woman for a cesarean section, the risk of hysterectomy, blood transfusions should be explained. We can offer her cell salvage if that is available, and we should keep cross-match blood available during cesarean section. Cesarean should be performed by adequately trained and senior experienced consultants. Sometimes we can consider vertical skin and uterine incision depending on the fetal position and the placental localization. It is not a routine, but it can be considered in certain cases, especially if the fetus is less than 28-week gestation. Sometimes mapping of the placenta before or during a cesarean also proves beneficial by an ultrasound scan that helps us plan the incision that we need to take. Intrauterine tamponade and surgical hemostasis by placental bed sutures should be initiated sooner and to avoid major postpartum hemorrhage. Placenta accreta. As you can see, some numbers again for you. The incidence in women with no previous cesarean is 3.3 to 4%. In one previous, it's 3%, two previous, it's 11%, three previous is 40, four previous is 61, five previous is 67. These are our important numbers, and questions may come from these numbers. As you can see, this is the placenta accreta spectrum. Depending on the number of layers involved, starts with accreta, and this is the percreta side of spectrum. The best modality of choice for diagnosis of placenta accreta spectrum is a transvaginal ultrasound done by an experienced sonographer. MRI is done to complement ultrasound scan to assess depth and lateral extension, more commonly in the posterior placenta when it is not clear by an ultrasound scan. These women should be cared in a specialist center for placenta accreta and a center equipped with all the necessary modalities to care for such women and to plan for delivery. The delivery should be planned between 35 and 36 plus 6 weeks of gestation. Of course, things may change depending on the scenario, depending on woman's condition. Risk of massive hemorrhage, bleeding, chances of complications like injury to bowel, bladder, blood transfusion, hysterectomy, secondary coagulopathies, multi-organ failure, and death should be explained to the woman in cases of placenta accreta spectrum during cesarean section. Proper consent should be taken and proper preparation should be done when planning for delivery. So the care bundle. So RCOG came up with a care bundle for management of placenta accreta and placenta previa. It involves 6 components, which are shown as follows, which includes senior consultants present, obstetrician and anesthetist, blood and blood products present, preoperative planning, discussion and consent for proper possible interventions, and availability of a critical care bed or an HDU bed for care of the placenta. These are the different stages of placenta spectrum: accreta, increta, and percreta. Now, what are the surgical approaches that need to be taken while planning delivery for such women? Cesarean section hysterectomy is one of the approaches that can be considered, and the placenta is left in situ. So we deliver the baby and we go ahead with doing the hysterectomy straight away. Other approaches that can be used depending on the grade and the amount of the placental involvement are partial myometrial resection, which is a uterine preserving surgery. So we remove the placenta along with the myometrium and then we reconstruct the uterus. However, there is high risk of bleeding and high risk of requiring a secondary hysterectomy at a delayed stage. If there is a bladder involvement, we have to do ureteric stenting, we have to do cystoscopy, and we should plan for a cystectomy depending where on the involvement of bladder, along with the hysterectomy and bladder reconstruction. Another approach is to leave the placenta in situ and continue follow-up and let it be inside. This is again a very risky approach because there is chances of secondary PPH, there is chances of infection, and there is chances of heavy bleeding at a later date. So regular follow-up of such women if we have left the placenta in situ, ultrasound follow-up to check for the placenta, and complications management is very important. Earlier, there was a recommendation to use methotrexate for the placenta left in situ. However, this therapy is not recommended. Interventional radiology, if is available in the setup, is an important approach and help decrease the bleeding in intrapartum and postpartum by stenting the uterine arteries and balloon coagulation. Vasa previa. Vasa previa is the fetal vessels that run through free placental membrane but are uncovered by Wharton's jelly or placenta. So these are free running fetal vessels which can cause fetal bleeding as the woman goes in labor. Because these are not supported by any placental Wharton's jelly or placenta. The prevalence of Vasa previa is 1 in 12,000 to 1 in 5,000. 1 in 1200 to 1 in 5,000. The fetal blood volume is at term is 80 to 100 ml per kg. This is important because that will be the amount of blood that is losing if there is a Vasa previa. Quickly, fetus can become exsanguinated, and it is very important if there is a Vasa previa to consider immediate cesarean section to save the baby. The best diagnostic modality is again an ultrasound scan, that is a transabdominal and transvaginal color Doppler imaging. Prenatal diagnosis can be done around 18 to 24 weeks of gestation, but the confirmation is done at 30 to 32 weeks of gestation. These are the placenta previa, that is the placenta covering the os, low-lying placenta, that is within 20 millimeter of the internal os, Vasa previa, where the fetal vessels are running freely, and as soon as the membrane ruptures, these vessels can get ruptured and cause bleeding. Management of Vasa previa. Cesarean section is recommended before labor onset because then it can cause fetal bleeding. Some women are at high risk of bleeding, and we consider hospitalization from 30 to 32 weeks of gestation for safe lodging. In preterm premature rupture of membrane, if we suspect there is a PPROM, we must offer immediate cesarean section. We must offer women steroids from 32 weeks. If there are no complications, or if the woman is asymptomatic, we can prepare for an elective section around 34 to 36 weeks of gestation, depending on woman's situation. That's it for the brief summary of antepartum hemorrhage. I have some questions which we can discuss together. The first question is, a woman attends the antenatal clinic following a scan at 36 weeks of gestation in her fourth pregnancy, which identifies an anterior placenta previa. She has had 3 previous cesarean births. What is the risk of placenta accreta? We discussed this before in one of the slides. It is important to remember these numbers because these can be asked in an exam. The correct answer for this is D, that is 61%. You are a specialist registrar performing an emergency cesarean section for a woman with previous cesarean at 37 weeks. Her 20-week scan has ruled out placenta previa. On opening peritoneum, you see engorged bluish vessels in the lower segment. What would be your course? Call for a consultant and wait till they arrive. Call for a consultant but continue opening the lower segment. Call for the consultant, proceed opening upper segment. Call interventional radiologist and wait till the stents are placed. Cross-match blood and proceed with the surgery. If you are suspecting a placenta previa, it is important for to ask for senior help because you can anticipate chances of major PPH. And what in this case we can do is call for a consultant and continue opening the lower segment because now the woman's ready on the table. We should start with the delivery of the baby. And by the time you do that, your consultant would be present to help you with the closure and management of the PPH. So that is the best option. A 32-year-old para 2 with previous placenta previa who is found to have a low-lying placenta at 20 weeks. At 32-week scan, it shows that the placenta is not low-lying, but there is Vasa previa. When would you plan delivery? With Vasa previa, there is chance of bleeding if the woman has a PPROM. So if we have diagnosed Vasa previa, we should aim delivery by 34 to 36 weeks, and we should also consider steroid injection before at around 32 weeks. We can consider admitting women to the hospital from 32 weeks for safe lodging. That is also an option. So the correct option here would be option F. Okay. That's it from my side for today. Thank you all for your patience listening. I will be happy to answer any questions that you have on this topic that you can send to me. Thank you.